This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub Podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Elara, Research Fellow. Today we're looking at a fascinating new study from BMJ Open, published in 2026, titled Harms of Selected Spinal and Paraspinal Injections and Denervation Procedures for Chronic Non-Cancer Spine Pain, a systematic review and meta-analysis of non-randomized studies.
This is a timely topic, Elara. As neurosurgeons, we see patients every day who have either already undergone these procedures or are being referred to us because these interventions failed. We often talk about the efficacy of injections and radiofrequency ablation, but we don't always have a clear, aggregated picture of the long-term or infrequent harms.
Exactly. Most of our data comes from randomized controlled trials, or RCTs, which are great for efficacy, but often too small or too short in duration to catch those infrequent adverse events. This study, led by Fahim Malam and colleagues from McMaster and the University of Ottawa, specifically looked at non-randomized longitudinal studies with at least 4 weeks of follow-up. They wanted to capture the harms that usually fly under the radar in short-term trials.
And that's a critical distinction for our residents and fellows listening. When you're consenting a patient for a simple injection, you need to know what happens beyond the first 48 hours. So, Elara, give us the broad strokes. What did the researchers actually look at?
They conducted a massive sweep of Medline, EMBase, and CNL up to October 2023. They ended up including 60 longitudinal studies, 56 of which were non-comparative and 4 were comparative. In total, we're looking at data from 4,966 patients living with chronic axial or radicular non-cancer spine pain.
Nearly 5,000 patients. That's a decent sample size, though spread across different procedures. How did they categorize the interventions?
They broke them down into 3 main groups. 31 studies looked at radiofrequency ablation, or denervation, 22 focused on epidural injections, and 11 looked at joint injections or nerve blocks.
Now, before we get into the specific numbers, I noticed the authors used the GRADE approach, the grading of recommendations, assessment, development, and evaluation. For the residents listening, that's the gold standard for appraising the certainty of evidence. Elara, what was the overall certainty of the findings?
It was actually quite humbling. Most of the evidence was rated as low certainty or very low certainty. This means that while we have these estimates, further research is highly likely to change our confidence in them. But even with low certainty, the specific harms they identified are clinically significant.
Let's dive into those specific harms. What were the most common or significant complications they found?
Let's start with one that every surgeon worries about: deep infection. The meta-analysis found that joint radiofrequency nerve ablation, joint-targeted steroid injections, and epidural injections of local anesthetics and steroids may result in deep infection with an incidence of about 0.7%.
0.7% sounds low, but if you're a high-volume pain clinic doing thousands of these a year, that's a non-negligible number of patients ending up with a potential spinal infection or abscess.
Precisely, and the 95% confidence interval for that went up to 2.0%. Another one was dural puncture. They found an incidence of 1.4% across epidural steroid injections and joint RFA. Again, low certainty evidence, but a 1.4% risk of a CSF leak or post-dural puncture headache is something the patient needs to know during the consent process.
What about the side effects that aren't necessarily surgical complications, but still impact the patient? I saw something in the paper about altered level of consciousness.
Yes, that was an interesting finding. Low certainty evidence suggested that joint-targeted and epidural steroid injections resulted in a temporary altered level of consciousness in 2.1% of patients.
That's a bit of a vague term. Does the paper clarify if that's vasovagal or perhaps a systemic reaction to the steroid?
The paper notes these were generally temporary and often resolved spontaneously or with conservative management. However, it's a reminder that these paraspinal procedures have systemic reach. Speaking of steroids, they also mention metabolic complications like glucose spikes and prolonged sensory deficits, but the evidence there was very low certainty, so we have to be even more cautious with those numbers.
One of the highest percentages I saw in the results was for prolonged pain or stiffness.
You're right, that was the most frequent harm reported. The incidence was 8.6%. This was specifically associated with dorsal root ganglion, or DRG, radiofrequency, and joint RFA, with or without steroid injections.
8.6% is significant. As neurosurgeons, we often see these patients in follow-up. They come in saying, "Doctor, I had the procedure to fix the pain, but now I feel even stiffer or have this new aching pain." We might dismiss it as a post-procedure flare, but this study suggests it's a documented prolonged harm for nearly 1 in 10 patients.
And that brings up an important point the authors made. Most of these complications, the pain, the stiffness, the altered consciousness, resolved with conservative management, but prolonged in this study meant it persisted beyond that initial recovery window.
Let's talk about the elephant in the room. We all know the horror stories: paralysis, catastrophic vascular injury, or death following a cervical transforaminal injection, for example. Did this meta-analysis capture any of those?
It didn't, and the authors were very transparent about why. None of the 60 studies they reviewed reported very rare but catastrophic harms. Because the total number of patients was just under 5,000, and these catastrophic events might occur in 1 in 10,000 or 1 in 50,000 cases, the study simply wasn't powered to find them.
That's a crucial limitation for our listeners to understand. A study reporting 0 cases of paralysis doesn't mean the risk is 0. It means the study size wasn't large enough to catch a rare event. The authors actually stated that the retrospective design of most of these studies likely results in an underestimation of the risk of harms.
Exactly. They also noted that there was a high risk of bias in many of the included studies because they were non-comparative. In a non-comparative study, it's hard to tell if the stiffness or sensory deficit is a result of the procedure or just the natural progression of the patient's underlying degenerative disc disease or stenosis.
So, if we are looking at this from the perspective of a neurosurgeon resident in clinic, how does this paper change the conversation with a patient?
I think it adds specific data points to the risk section of our discussion. Instead of saying there's a small risk of infection, we can say, based on a 2026 meta-analysis, the risk of a deep infection is around 0.7% and about 1.4% for a dural puncture. It also helps us manage expectations regarding post-procedure pain. Telling a patient there is nearly an 8% chance of prolonged stiffness or pain actually makes them less anxious if it happens because they were prepared for it.
And it reinforces the low certainty of the field. We often act like these procedures are totally benign, but this paper shows that our evidence base for their harms is just as thin as some of our evidence for their benefits.
One other thing that caught my eye in the paper was the role of the parallel guideline panel. The researchers didn't just pick which harms to look for in a vacuum. They had a panel provide input on the scope and interpretation. This included selecting the adverse events that actually matter to patients and clinicians.
That's a great point. It makes the results more patient-centered. Instead of just looking at technical success, they looked at prolonged pain, which is what the patient actually cares about.
To wrap up the data, we have 60 studies, roughly 5,000 patients. Low certainty for deep infection, 0.7%, dural puncture, 1.4%, altered consciousness, 2.1%, and a higher incidence of prolonged pain or stiffness, 8.6%.
And the takeaway for the practicing neurosurgeon? Don't assume minimally invasive means no harm. While most of these issues are manageable, they are real and they are frequent enough that we will all encounter them in a busy practice.
The authors concluded by saying that further research is highly likely to have an important impact on confidence and effect estimates. So this isn't the final word, but it's the most comprehensive look we have right now.
Well said, Elara. This has been a great deep dive into the 2026 BMJ Open Study. For our residents, take a look at the full text. The breakdown of RFA versus injections is particularly useful for your pain rotations.
Thanks for listening to the Neurosurgery Hub Podcast. We'll link the study in the show notes.
Until next time, I'm Dr. Aris.
And I'm Dr. Elara. Keep learning.